Have you ever had numbness or weakness in your hand, or felt that you're maybe dropping objects, or that when you're typing on a keyboard you're in a lot of pain? Well, you might have something called carpal tunnel syndrome, which is a very common clinical entity that a lot of people have. In this video, I want to talk about what carpal tunnel is, what the risk factors are, how we diagnose it, and also what the best treatments are for this condition. So let's get started. My name is Dr. Sater. I'm a double-boarded pain doctor and neurologist in Connecticut and New York. All right, first of all, let's define the carpal tunnel. So the carpal tunnel is essentially a tunnel that is in your wrist and that comprises a bunch of tendons. So the tendons that essentially control your fingers, blood vessels, as well as the median nerve. So the median nerve is basically one of the main nerves that control your hand. And that nerve controls sensation in your thumb and your index finger, in your middle finger, and also half of your ring finger. Okay, so all of that region potentially is controlled by your median nerve. What are the symptoms of carpal tunnel? Carpal tunnel syndrome will basically lead to numbness in those 3 fingers and a half. So it will feel either numb or pins and needles sensation, what we call paresthesias. For other people, they might describe it as heaviness. And then other people might actually feel that it's their whole hand, right? Although, if you do test them, then it tends to be clear that it's actually the 3 fingers and a half. Now, in severe carpal tunnel syndrome, you can also have weakness, motor weakness, and then there will be pain at the wrist level. And usually in the exam room, when we are tapping on that region of the wrist, a lot of times patients will feel pain and an electric shock going down to their fingers or going up potentially to the elbow. Now, what are the risk factors for it? So there's a lot of different risk factors, but in general, anything that involves a lot of motion at the wrist level will put you at risk. So typing, for example, the manual work, like let's say you're a cashier who is, doing a lot of stuff with their hand, construction work, anything that involves a lot of motion at the wrist level will put you at risk. Now, there's other conditions that will put you at risk for another reason. And so, for example, pregnancy and some thyroid disorders can lead to median neuropathy and carpal tunnel because of the increase in fluid and the swelling that can happen inside that tunnel, especially if somebody is already at risk. All right, now, how do we diagnose it? So the diagnosis for carpal tunnel is usually a clinical diagnosis. So you need to have the classic numbness. Sometimes we look for signs on physical exam. Like I mentioned, when we tap, we call that the Tenel sign at the wrist. Sometimes we get nerve conduction studies. So it's called an EMG, electromyography, and nerve conduction studies, where basically we zap you with electricity and we find the speed of the nerve. So let's say that a nerve normally conducts at 50 or 60 meters per second. If there is compression of that nerve at the wrist, then there's demyelination, right? So it's almost like that nerve is losing the sheath that makes it fast and insulated. And so that speed goes down. So now it's conducting across the wrist only at 40 meters per second. And so we use that to our advantage to be able to tell if there's any conduction block that's happening at that level. And also it's important to use that to distinguish carpal tunnel from some of the confounders. So, for example, if people have a disc herniation in their neck, and that's what we call cervical radiculopathy, and it's potentially that in itself can also lead to numbness and weakness and similar symptoms in the hand, right? So let's say it's a C6 or a C7 radiculopathy that can mimic carpal tunnel and lead to numbness and weakness and similar symptoms. Usually, it's also going to lead to pain from the neck shooting all the way down, but not always. And that's why we sometimes use nerve conduction studies to distinguish between the two and make sure that we are indeed dealing with a carpal tunnel picture. Now, let's talk about treatment. So the first line treatment for this is more conservative, and basically that involves splinting. So by putting a wrist splint at night and wearing a wrist splint at night, that basically will decrease the motion and the inflammation that is going to happen overnight to that carpal tunnel. Because at night we move around a lot without knowing it, and we might be compressing it in ways that is exacerbating the symptoms. So by putting that splint, it will alleviate the compression and potential inflammation of the carpal tunnel. However, if it's a more moderate or severe carpal tunnel, then splinting a lot of times may not be sufficient. So then we move on to medications. Sometimes nerve medications can help, like gabapentin and pregabalin. They do come at the risk of sedation sometimes, depending on the dose. But these are some of the considerations. And for some people, that's sufficient, right? So like doing the splint combined with the gabapentin. And then if that doesn't help, we usually move on to injections. So steroid injections inside the carpal tunnel help a lot, and the benefit can last for 6 months up to a year, which is longer than what I've seen in other kind of steroid injections. And that potentially could be because it's in a very confined space in the carpal tunnel. And maybe that's why it lasts longer. But I've had patients who basically get the injection only once a year, and then they're doing great for a whole year, and then they come back for a repeat. And then the final and more definitive option would be surgery, right? So carpal tunnel release, where basically the flexor retinaculum is cut to alleviate that pressure. Now, unfortunately, that's not permanent because there could be scar formation. There could be formation of scar tissue down the line, maybe in a few months or years, usually a few years down the line, that will potentially recreate the same phenomenon of carpal tunnel. So just because you had surgery doesn't mean you're not prone to getting it again. And a lot of it is going to be down to preferences. Some people don't want surgery, and so they prefer to simply have the injection once a year, once every, or twice a year. Other patients want something more definitive, and they don't want to do steroid injections, and that's fine too, right? So that's where the conversation is between patient and doctor to discuss all the risks and benefits and decide on the optimal treatment. And the injection is best done under ultrasound guidance, because that way with the ultrasound, we can actually see the nerve, we can see the vessels, the ulnar and the radial arteries, and then that way we can stay away from all those structures, but also make sure that we are inside the tunnel. So that increases efficacy and safety of the procedure. And it's a really quick procedure. It takes about 30 seconds for the whole thing.